Hello, everyone, and thank you for joining us on this beautiful Friday. Well, it's very beautiful here in Wisconsin. It's actually going to be like 65, so that's really exciting for a fall day. But thank you so much for joining us to our Elektra expert event. For those of you who don't know me, I'm Laura. I'm one of Elektra's guides, and our special guest today is Dr. Anna Barbieri, and I'll give her a little brief intro in just a minute. But a couple of things, just if everyone could put themselves on mute, that would be fabulous. And the kind of the structure of the event is very simple. Anna and I will be talking. She'll be sharing her vast wisdom about HRT, hormone replacement therapy, for the first 20-25 minutes or so. And then we're going to go into some Q&A from anyone who is in the audience. And if you have questions along the way, just feel free to put them in the chat as the event goes. You don't have to wait till the end to do that. So let's get on with the show today. I'm thrilled to introduce Dr. Anna Barbieri, who is our expert guest. She is also Elektra's founding physician. She is a board certified OBGYN. She is certified by the North American Menopause Society. And she's also certified, board certified in integrative medicine. And she is the one that's really kind of given Elektra our very holistic approach to menopause support and menopause care. She is fabulous. She is a font of knowledge about menopause and HRT. And we're thrilled to have you here, Anna. You're fabulous. Welcome.
Thanks so much, Laura, and welcome everyone. We thought, whenever we do these events, there's always HRT questions that come up, and it's such a broad topic, and we can never do it justice in like the 10 minutes that we have devoted to HRT and any sort of, general menopause conversation. So we thought about kind of focusing on that topic today. I would love to give everyone sort of a general overview and then take some questions, because the questions always pop up on this, and maybe we'll have some time to answer them today. Glad to be here today. Welcome everyone again, and let's get started. So starting off with a definition, what is HRT? So HRT stands for hormone replacement therapy. That name is actually changing now a little bit. So you may see the initials MHT in some sources and publications. MHT stands for menopause hormone therapy or menopausal hormone therapy. What we mean by that is really typically 1, 2, or more hormonal tools that are used to manage the symptoms of the menopausal transition and menopause. And MHT or HRT, we can think of as divided into kind of 2 broad categories. One is systemic or generalized HRT, which really means hormones that affect our bodies as a whole. So these hormones circulate throughout, have an effect on all the various different organ systems, and are usually administered either orally or through our skin as patches, as gels, as sprays, as creams. That's very different from something called local or topical HRT, which is also hormonal therapy that's really reserved for vaginal administration. And that means hormones that are typically used to offset symptoms of vaginal dryness, pain with sex, frequent UTIs. They can help with prevention of that. So these are really hormones that are suited to local activity and have minimal to no absorption systemically, meaning to our bodies. And when we have these conversations, when we read about stuff about the controversies of HRT/MHT, that really has much more to do with that first category. So hormones that are absorbed throughout, that circulate throughout, rather than topical hormones. And topical hormone therapy is sort of easier to go over. It doesn't take as much time. It's really either estrogen or maybe estrogen and testosterone or another hormone called DHEA. And that's really used mostly for vaginal dryness, for pain with sex, for UTI prevention after menopause. And it can have all of these benefits without necessarily giving us other benefits of systemic HRT nor the risks of HRT. And low-dose vaginal therapy is quite safe. It is even used in certain patients, certain women who may have a history of breast cancer, and we use it quite widely. It comes in different formulas, different methods of delivery. So it can be little pills, inserts, there's a vaginal ring, creams, and so on. So usually when I talk to patients about that, and we're going to use that approach, we'll focus on what is convenient, usable, what someone can sustain. And we focus also on cost. I do think that we need to have, whenever we talk about therapies, we need to be cost conscious. Some of these can be quite expensive and different plans cover them at different rates. So I do mix that into the conversation as well, so we know what we're choosing. That's the easy part. Any questions actually about that before we move into this more sort of robust discussion of the other type? All right, I'm going to keep going. All right, so let's talk general or systemic hormone therapy. That means hormones that we use that are typically at higher dose and that circulate throughout our bodies. Usually what we mean by that is hormone therapy with mainly estrogen. This is going to be the big one. Estrogen has been used for hormone therapy for menopause for many, many years, almost 100 years, actually, maybe 80 or so, since 1942. It has a pretty rich history of being very widely used from the 60s through the 90s. Then prescriptions for it went down after a certain big study was published about 20 years ago, and now hormone use is on the rise again. Estrogen, we all make estrogen. We all, as long as we live enough, are going to start producing less and less estrogen until that estrogen production is really minimal. Most estrogen production takes place in our ovaries, but we do make some estrogen in other parts of the body, especially in our fat stores. So, I don't know if, people here are aware, for example, that women who may get estrogen positive breast cancer, even at the age of 65, they will often take estrogen blockers that will further decrease estrogen in their bodies because they are still making a little bit of estrogen. Many of the symptoms of menopause that we think of classic symptoms, hot flashes, night sweats, vaginal dryness, and so on, loss of bone density, have to do that with that estrogen drop. And many of them happen, even including mood changes, because of the pretty kind of sudden drop in estrogen. In our 40s, estrogen overall starts to go down, but tends to be very erratic, sometimes higher than normal, often lower than normal. And usually by the time we get to late perimenopause and menopause, after menopause, it sort of is the ovaries basically stop producing it and it's released at a very, very low level. Hormone replacement for estrogen has many shapes and sizes. It can be delivered either as an oral pill. It can also be delivered through what's called transdermal administration. And what that means is through the skin. And there it comes as either a patch, gel, spray, cream, and so on. Estrogen and progesterone, I'll talk about progesterone in a second, has many, many benefits in terms of its use. There are both short-term benefits. Sleep gets better, hot flashes, night sweats basically can disappear. Vaginal dryness, even with systemic use, will also get better. There is typically an improvement in mood, especially for women who tend to feel anxious and depressed without estrogen on board. Many women report that their skin gets a little bit sort of starts to regain some of its elasticity, hair can get better. Libido is libido is complicated, but some women do report improvement with that. And kind of a general sense of well-being. There are also some longer term benefits that we may not feel directly after a few weeks of usage, things like lower risk of osteoporosis, things like lower risk of cardiovascular events, especially in the decade after starting on estrogen therapy, slightly lower risk of colon cancer. There's also a lot of exciting research going on about cognitive benefits of estrogen, meaning protection from memory loss, perhaps, and I don't want to say that HRT protects us against Alzheimer's disease and dementia later on, because those findings are quite complicated, but there is a lot of current investigations going on into that. There are also downsides of estrogen. One of the downsides, and many of us, I think, on this call are of the age where we can remember that birth control pills, for example, can cause blood clots, right? And increase the risk of stroke. The same thing goes for oral estrogen. So oral estrogen can be associated with an increase in inflammatory factors, increase in cardiovascular complications, and even an increase in the risk of stroke, especially for women who have predispositions to those conditions. For that reason, we tend to favor transdermal, meaning through the skin applications. And in women who use transdermal applications, we do not see an increase in those events over baseline, down to the fact that, for example, we use transdermal estrogen even in women with a history of migraine. I use it carefully in women with a predisposition to blood clots, and we often take a look at those genetics and try to calculate the risk. There does not seem to be an increase in that. Estrogen can be used on its own in women who have had a hysterectomy. As a matter of fact, when we first started to use estrogen on a wider basis, so really in the 60s, it was thought that we only needed to use estrogen. And lo and behold, 15 years later, we realized that estrogen on its own, as good as it is, it can also cause some problems. And one of them will be an increase in the growth of the lining of the uterus, because estrogen acts like a growth factor on that part of the body. So we need to balance it with its sort of sister hormone, and that's progesterone. Progesterone is the hormone that goes up in the second part of the menstrual cycle, and it dampens the effects of estrogen, especially on uterine lining. This is what prevents endometrial cancer or uterine cancer that can occur when we are exposed to too much estrogen without the balancing benefits of progesterone. But just like with estrogen, we have receptors for progesterone everywhere. We have receptors for progesterone in our brain, in our blood vessels, and progesterone, like estrogen, has effects on those organ systems as well. One of the main effects of progesterone, especially natural progesterone, is really an effect on relaxation and sleep. Progesterone and estrogen have really significant effects on neurotransmitter systems, especially something called GABA for progesterone and serotonin for estrogen. Often we see in perimenopause, especially early, so on average early to mid 40s, many of us stop sleeping as well as we did before, especially during our periods, and that may be related to a drop in progesterone that happens earlier than drop in estrogen, and that's because progesterone will impact those GABA neurotransmitter pathways. Progesterone, sometimes I use it for women in perimenopause for sleep, and things do tend to get better, but certainly in women who have not had a hysterectomy, progesterone is used as a way to protect the uterus from the effects of estrogen only. When it comes to risks of hormone therapy, aside from the cardiovascular risk that oral estrogen carries, that we can do away with by using transdermal versions of this hormone, everyone always mentions the risk of breast cancer with hormone therapy. That's been a hot topic for multiple decades, and much has been written about it. And even in 2022, many of us are still kind of confused about how it works and what it does. So, and the reason that is because up to about 80% of all breast cancer diagnoses will be diagnosed in women who have what's called hormone positive breast cancer. So when someone is diagnosed with that, typically that tissue is analyzed, and you will hear about estrogen positive, progesterone positive breast cancer. It's very common. And then the question is, well, if that cancer tissue has those receptors, what does that really mean? Did it happen because estrogen and or progesterone stimulated it to happen? Did it happen because these hormones were the causal factors of it? Did these hormones enable that cancer to grow more quickly or more aggressively? And if we block those hormones or lower them, does that cancer get cured at higher rate, or does it come back at a lesser rate? And we do know that in women who have these hormone positive breast cancers, certainly the use of hormone blocking therapy, like tamoxifen, like things like anastrozole, these are estrogen or hormonal blockers, will decrease recurrence rates, right? So how does hormone therapy play? What role does it play in breast cancer? And maybe if it's going to increase the risk of it, well, maybe none of us should use it. And that really was a very superficial and easy conclusion of this study I mentioned that was done 20 years ago, that really was not so great in neither its design nor its analysis. And basically the conclusions of the study said, hormone replacement, as good as we thought it was, really increases the risk of breast cancer by as much as 26% after 2 years of use. So basically overnight, that led to a sudden decrease in prescriptions for hormones. Lots of women who were unhappy with that. Many women went to hormones that were proposed to be safer, nature-derived, compounded, and so on, because they were touted as sort of the safe version of hormone therapy. And everybody started to be so afraid of this breast cancer link and hormones that they just prefer to stay away. And that goes for both women patients, that goes for providers in the healthcare system. Amazingly, 20 years later, many people still feel like that, even though we do have some more information and better information about this link. So where are we in 2022 on that? We do know that use of hormones, especially for a longer period of time, especially when estrogen is combined with progesterone-like compounds after some time, can increase the risk of breast cancer being diagnosed. We think that that applies especially to women who are at higher risk. And we think that the use of hormones may not even cause breast cancer to start happening, but it may encourage small and very early breast cancer to grow. I hope that makes sense. We know that the risk of breast cancer may be higher with certain types of hormones. And fortunately, those hormones are not used today as widely anymore. It is higher in women who use estrogen and versions of progesterone that are different than progesterone that we make in our bodies. So they're going to be called synthetic or lab-made progesterone-like substances, especially those that are delivered that are combined with oral estrogens. When we try to kind of separate all this, like the weeds of all the data, it does look like estrogen that's delivered through the skin, and progesterone that's delivered in the form that our bodies make. I'm going to call it natural or bioidentical progesterone, but certainly there are regular FDA approved versions of that. Like you can literally get it at CVS. We do not see an increase in the risk for breast cancer up to 5 years of use. We don't know exactly what happens at year 7 or 8 or 10 or 15 because we just don't have that data. We do have some information about increasing risk of breast cancer after 5 years of use when we look at everybody on all these different mix of hormones. And the answer, yes, it may go up slightly. What does that really mean? With every patient that I, for example, write hormone prescriptions for, we sit down and calculate their risk based on their individual risk factors. Your age, your pregnancy history, your family history, your ethnicity, personal history of breast biopsies, and so on. So where we are today is that, yes, long-term use of HRT can increase your risk of breast cancer, especially if you're using synthetic progestins. That risk can be minimized if you use natural progesterone. That risk is minimized if it's estrogen only. And in fact, in many studies, we do not see a rise in breast cancer with estrogen only. But we need to assess it individually and really compare it to all those benefits of hormone replacement that I mentioned before. It's never to me, it's never kind of a one-sided issue. You kind of have to weigh both of them. We mentioned some terms here, especially bioidentical and synthetic. So what does that really mean? Bioidentical really means that the hormone is in the same form that humans produce. This is going to be really estradiol for estrogen and progesterone for progesterone. There are synthetic versions of both of these hormones that can be used, and they have their role. And then we get into just really nuances of treatment in terms of what people need and whether they have any issues with tolerating different forms. But really kind of the standard to go first line treatment in our practice at Elektra, and certainly in my personal practice, is to use estrogen through the skin and bioidentical FDA approved progesterone. Bioidentical hormones can also be compounded. I don't know if any of you have experience with compounding of hormones. Compounded hormones are made in special pharmacies to kind of specifications of the physician prescribing it. Some advocate that they are safer. We actually don't know that. As a matter of fact, they are less regulated than standard FDA approved preparations. So I typically start with those. They're also more expensive. On the other hand, and I think you probably are hopefully getting a sense of this from Elektra, we tend to be, we want to be a really thoughtful company. And I certainly don't subscribe to the notion that we should never, ever use compounded hormones. I do think that the use of FDA approved regulated hormones is safer to start with. But there may be individual circumstances when someone may need to use compounded hormones, including people who are allergic or need some special combinations. They tend to be a little more expensive. Usually the hormones that are covered at a higher rate are going to be the regular prescription hormones. And we can certainly have a number of different combinations. There are different dosing and so on. Best time to start? I know it's like we're running out. Okay, any questions about that?
So Anna, actually, Lisa had a great question.
Yeah.
Why would anyone, because of that risk of cardiovascular side effects goes away with that transdermal, why would anyone take an estrogen pill?
Yeah, so for some people, it's just easier to take an estrogen pill. Some of those products are going to be cheaper also than transdermal products. For some people, it's easier to remember to take a daily pill rather than change a patch every 2 weeks. Twice a week. So it's those reasons. And when you give the pill, an estrogen pill to a super healthy 51-year-old, probably, there is some difference in risk, but it probably doesn't make that much of a difference. That risk between transdermal and oral is not as great.
Got it. Interesting. I had a friend who actually her insurance wouldn't cover the patch, but it would cover the pill. So
Yes.
that goes to the cost reason for sure.
Yeah.
Any other questions?
So Beth and everyone knows and Laura that are here because I've been on hormones. And I'm in perimenopause. So I know some people have different opinions, it's changing. Like, should you start them in perimenopause, in menopause, and how long? Because there is thinking now these days that there's other protective. So it's, people are starting to use them longer term just because of their, health or lifestyle or whatever.
Yeah, I mean, I think that's a great question. So starting with when do we start? There definitely seems to be this quote window of opportunity when the benefits are going to be max and the risks lowest. And that's going to be around the time of entry into menopause and no later than 10 years from it. Having said that, typically symptoms of the menopausal transition are going to peak around, late perimenopause. So roughly 2 years before that last menstrual period and throughout, and for a couple of years after. So most of the time, I would even venture to say that it's best to start around that time, both at Elektra and then, in personal practice. Usually we start really late perimenopause and use components of hormone therapy if needed in early perimenopause too. But certainly, a perfect time would be after that last menstrual period, but we can definitely start before. I certainly don't subscribe to the notion that we need to make sure somebody is in menopause, so wait 12 months from the last menstrual period before starting. It's not really humane. If somebody is really suffering with symptoms, it's like, you've got to try to get pregnant for a full year, even if there's obvious signs of something not being right before getting treatment. Like, no, someone is in perimenopause and has really significant symptoms. We can start then. As far as how long to continue, great question. Also, it's no longer, lowest dose for shortest duration of time. Usually usually that treatment looks, to be at least a couple of years. Of course, it can be stopped or changed if somebody is having side effects. I typically rediscuss the risk of breast cancer and reassess everything at every visit, after somebody is on these and everything is going well. It can be annually, definitely at 5 years. But I do have some patients who are using hormones well into their 60s or even 70s who may have tried to go off before and they simply feel much better. And if they're, if all of their screening and everything is fine, I think it's okay to continue them. And I think this is an answer that very well may change over the next 5 to 10 years as we get more data and on long-term effects of MHT. I would not be surprised if we continue it longer, but I can't say yet that that's the guideline or recommendation.
Great. And I have one last question, and this is one that we actually get asked a lot, and it's the use of oral contraception as a kind of a form of hormone therapy for women. A lot of women seem to think that that's like some sort of like cop out when their doctor talks to them about that, but talk about, the reason why you would use the birth control pill for this.
Yeah. So birth control pills are hormone therapy. I mean, that they are made from versions of estrogen, progesterone. Yes, it's typically an oral synthetic estrogen and an oral synthetic progestin, but it is hormone therapy. Often they're going to be used earlier, so in perimenopause specifically, and there is actually a good reason for that. So in perimenopause, the reason we feel the changes of perimenopause is because of not just hormones being low, it's because of how widely they fluctuate, right? So if our hormones are up and down in an unpredictable way, we feel that. Doing full-on menopausal hormone therapy during that time is rather difficult because hormone levels can change daily. So whatever we start people on in terms of these low dose, transdermal estrogens, natural progesterones may not be really appropriate for what happened yesterday and what's going to happen tomorrow. Low dose menopause hormone therapy or traditional HRT does not suppress our own hormone levels. So if our own hormone levels are going up and down, using that is going to leave us kind of chasing our own tail all the time. Birth control pills, because they are a higher dose hormone therapy, they cause our own hormones to go down. So we take them and our brains go, okay, there is enough of this on board. I'm going to stop managing hormonal production. So we see a decrease in the signals from our brains that go to our ovaries. Our own production of estrogen, progesterone goes down, and it's replaced by this steady state in the birth control pill. So for that reason, it's used in perimenopause to really take away the ups and downs and superimpose a steady level. It's a very valid reason, and we use it too, and it can really be a game changer for many women. But just like any intervention, it has its downsides also, including a higher cardiovascular risk, including certain emotional side effects that some women can have, especially due to the progestin type and so on. So it's not for everyone, but it can be, when used in the right circumstance for the right person, it can totally be a game changer.
Awesome. Thank you so much. So we're a little bit over here. If anyone has any questions, please feel free to put them in the chat kind of right now, and we can kind of get these answered in writing and kind of send that out after the event. But we did record this. We're going to be posting it on the feed. So that'll come up in the next day or two. And Anna, thank you so much. This was great. Every time I listen to you talk, I learn like new things, and thanks to everyone who joined us today. Thank you for being part of the Elektra community. And if there's any other events you would like to see, any experts you would like to hear from, or topics you'd like to hear about, you can email members@elektrahealth.com. Thank you, everyone, and have a wonderful weekend.
Thanks, everyone.